Hi, this is Kristen Rash, and this is my Grand Rounds presentation on pathophysiology for the registered nurse, and mine is on disseminated intravascular coagulation. Now, in our case study, the patient is a 66-year-old white male who was admitted with spontaneous ecchymoses over his limbs and a 10-centimeter hematoma on his left laterocervical and supraclavicular region. Rectal examination revealed a large and hard prostate. No clinical signs of infection or hepatic failure were noted. Past medical history included arterial hypertension and benign prostatic hyperplasia, and there was neither antiplatelet nor anticoagulant therapy being used. 2 months earlier, his PSA was 40 without identifiable malignancy upon biopsy. Now, laboratorial investigation showed a hemoglobin of 12.1, leukocytes of 9,340, platelets of 115,000, PT of 17.1, PTT of 33.4, D-dimer of 61.7, fibrinogen of 72. His PSA level is now 385, while his creatinine, urine, and liver enzymes were normal. Transrectal echography was performed, revealing an abnormal prostate, and upon biopsy, adenocarcinoma was identified. His scans revealed no visceral metastasization, and his bone scan did reveal presence of lesions of the left scapula, body of L4 and L5 vertebrae, and sacral region. The diagnosis of DIC was given with enhanced fibrinolysis, and the patient started treatment immediately. After 5 days, there was a remission, and he was discharged home. 2 days later, he was readmitted with a massive right hemothorax. His hemoglobin level was now 4.8, hematocrit 14, leukocyte count 13,000, platelet count 154,000, PT of 15.1, PTT of 21.8, D-dimer was now 37.42, and fibrinogen was 100 milligrams per deciliter. A chest tube was inserted, and supportive treatment through blood products was started over 3 days. After 3 days, the drainage still remained active, so IV EACA was started with a progressive reduction in chest tube drainage, which is exactly what you're looking for in that situation. After 48 hours of treatment, the chest tube was removed, and the patient was discharged with stabilized lab values. 6 months after the diagnosis, he died result of brain trauma, but that was unrelated to the DIC. Formation of fibrin clots in thrombotic occlusion of small and medium-sized vessels is what results from the intravascular coagulation. So it's a result of widespread activation of the coagulation system. Simultaneous coagulation and bleeding occurs within the vascular space because there's a whole bunch of clots that are formed, and it uses up all the clotting factors. So then, since all the clotting factors are used up, then the patient's at risk for bleeding. Massive hemorrhage and multi-organ failure can occur from this. This always presents secondary to a primary disease. And to determine treatment, you must determine what the primary disease is first. It can result from all different disorders such as inflammatory, infectious, or malignant conditions, basically anything that can activate the clotting cascade. In terms of pathophysiology, it's characterized by simultaneous clotting and bleeding within the vascular space. This is a result of basically two categories of diseases. So it's tissue injury, where the DIC is initiated by the extrinsic pathway and the liberation of tissue factors. So when that tissue is injured and broken down, then the tissue factors are released. Or endothelial cell damage. In that case, it's initiated by the activation of factor VIII. They both result in the platelet activation, which cause widespread clotting, and the body lacks the ability to control this and put a stop to it. They can occlude small vasculature and cut off blood supply to tissue and organs. And then in the case of DIC caused by cancer, cytokines such as tumor necrosis factor, they act as the mediators. They increase the amount of tissue factor released as well as decrease the release of thrombomodulin. So the whole regulation aspect is out of whack. For incidence and prevalence, there's many disorders and conditions that may result in DIC. So it's difficult to determine the general prevalence, but in terms of malignancies, DIC is the most common coagulation disorder that is a direct result of prostate cancer. So it occurs in 13 to 3% of these patients, while only a small portion of those actually exhibit tangible signs and symptoms. It occurs most commonly following manipulation of the prostate, which is exactly what we saw in this case study. The significance is you really need to understand the causes and risk factors so you know which of your patients are at risk for developing this disorder. So once you know that your patient may be at risk, then you're really on the lookout for different signs and symptoms, and you really need to pick up on the early warning signs, because if you pick it up on early, it really improves the patient outcome. Um, and the causes are from tissue injuries such as trauma, burns, obstetric complications such as retained placenta, surgery and cancers, and then endothelial cell injuries such as infection, shock, vasculitis, hypoxia, and so on. Basically, anything that potentially affects the body's natural coagulation system can start this clotting cascade and result in disseminated intravascular coagulation. The causes are essentially the risk factors. So in terms of risk factors, you're looking at those primary diseases which result in DIC, because it's actually a reflection of an underlying systemic disorder. The clinical manifestations are generally the ones that you would notice are generally due to the bleeding aspect of the disorder rather than the clotting aspect. So if you're in terms of the milder versions, bleeding from like IV sites, purpura, petechiae, or ecchymoses, such as in the case study, are things that would be picked up on pretty easily. And then the severe version would be hemorrhage. Then the less direct clinical manifestations are due to the microthrombi. So that would be when they start to block off those small vessels and they result in organ death, multi-organ dysfunction syndrome. It reduces or completely blocks off the blood supply and everything to these organs. So it can manifest as renal, circulatory, or respiratory failure, as well as GI issue bleeding, such as bleeding ulcers. And if there's neural involvement, then it can manifest as convulsions or coma. One other thing that these patients can exhibit is hemolytic anemia due to all these little microthrombi in the vascular space. When the red blood cells are trying to get by, they get damaged and lyse. So that can be another manifestation of this disorder. In terms of diagnostics, we're going to talk about lab values, PT, PTT, platelet count, fibrinogen level, as well as a marker of fibrin degradation, such as D-dimer or the soluble fibrin monomer. No one single skewed value is going to be a marker for DIC, but just a combination of these results taken at different times can give you a definitive diagnosis. So, such as in the case study, the patient had elevations in PT, PTT, and D-dimer, while his fibrinogen was decreased. So this all combined is a really good diagnosis tool for DIC. In terms of therapies and medications and all that, in the case study, the patient was initially treated with fibrinogen, stabilized, and sent home. But then when he presented back with a hemothorax and massively, skewed lab values, then he was treated with blood products, used the fresh frozen plasma, packed RBCs, and fibrinogen. That's like a more aggressive treatment when active bleeding is being shown. So also with the treatment, it's really focused towards treating the underlying cause or disease process, because a lot of times if you're able to correct that underlying cause or disease process, the clotting and bleeding can kind of regulate back on its own, and you can fix it just that way. If there is massive bleeding involved, then you're going to treat it with blood products. On the other hand, and that's including, platelet concentrate, fresh frozen plasma, fibrinogen. They're given with massive bleeding, or if you're having an invasive procedure to try to correct the underlying cause. So, like if it was a malignant origin and we needed to have a surgical intervention, then we would treat with blood products. And then on the other hand, heparin can be used, but this is not recommended for patients that are showing active signs of bleeding, for the risk of, drastically increasing that bleeding. This is only indicated for those that have the non-symptomatic type of DIC, where the clotting and embolisms are the concern. There's also protease inhibitors that are used, synthetic or natural. They work in multiple ways, such as, working against the effects of the fibrinolysis and the coagulation system. And these are used kind of as secondary treatments and backup treatments for if there's like additional support needed. The goals of treatment is basically to treat the primary disease, which is causing the DIC, because a lot of times that will reverse it on its own. Also, if it's the bleeding type, the goal is to stop the bleeding. If it's the non-bleeding type, it's to stop the clotting cascade. And then other goals are to prevent death, prevent the organ dysfunction, and this is why it's really important for early diagnosis so that you can preserve the organ function. So serious complications, if not caught early, it's much more serious. So we're talking about emboli occluding vascular and cutting off supply to organs or limbs, resulting in hypoxia or necrosis. So they could actually lose organs or limbs from this. And depending on where the emboli lodge and occlude the blood supply, you could have, respiratory, renal, heart, or organ failure, as well as the neurological complications that we discussed earlier. Unfortunately, sometimes these serious complications can actually be the first presenting signs that lead to the diagnosis. So that's when the outcomes are much less likely to be positive. And then when we're talking about the bleeding type, the most serious complication is massive hemorrhage. Prognosis really varies depending on the cause of the disorder. But if it's, the sudden life-threatening and it's a medical emergency type, it has much higher morbidity rates than the DIC that prevents slowly. Typically, they can be stabilized and the bleeding is regulated, but sometimes it's just too severe or the clotting is way too progressed to be able to be corrected. But in this case study, the patient was able to be stabilized and treated for both the prostate cancer as well as the DIC. Now, in terms of evidence-based nursing interventions and goals, these patients are at high risk for bleeding and hemorrhaging. So you really want to be extra cautious of falls because, what could be like a benign fall in a lot of patients could be life-threatening to the DIC patient due to the complete inability to control bleeding. So you want to do, really round with purpose, keeping the bed in the lowest setting, assistance anytime that they're ambulating out of bed, call light within reach, and sometimes they'll have strict bed rest orders, like the physician will not want them out of bed for any reason. And then when we're talking about the clotting aspect, they're at high risk for, DVTs, Ps. Venous clotting is a huge concern with these patients, but, typical prophylaxis can be contraindicated, like the sequential compression devices and TED hose, because of the risk of bruising and bleeding just from the pressure of those. So mild interventions that can be used can be range of motion exercises, consulted PT, and to promote activity as allowed and tolerated to help prevent emboli within the patient. And then in terms of pressure ulcers, there's decreased tissue perfusion in these patients. So we need to turn them with a thorough skin assessment every 2 hours, promote tissue integrity, and to minimize blood pooling and stasis, which can happen in the back if they're, in one spot. They need to be kept clean and dry, and really take good care of their skin. A lot of the padded bandages that we use can't be used here because they can tear the skin. So you really want to preserve skin integrity and prevent any and all breakdown. So I hope that was a good look into this disorder. Thank you for watching.